Welcome everyone. My name is Vicky Heaton and I'm Healthcare Relations Manager at the Macular Disease Foundation and also a practicing optometrist. Thank you very much for joining us today for what I think is going to be an insightful session on diabetes and its ocular complications. So let's start with some housekeeping. So all your cameras and microphones have been turned off. If you do have questions, then please put them into the Q&A box at the bottom of your screen. We will be answering these at the end of this presentation, but please feel free to type them out and pop them in at any time as we go along. So as you can see, the webinar has been accredited and endorsed by Optometry Australia and the Australian Diabetes Educators Association, and that's for one CPD hour and one CPD point. And the learning objectives are up here on the screen. So the webinar is being recorded and we will be sending these out to you next week. And I'll also include any links or any sort of extra information that's in the webinar in that email as well. So before I introduce our speakers, I'll just share some information on what we're doing at the Foundation to support our health professionals and the important work that you do. We do have a quarterly e-newsletter called Macular Matters, and that provides updates on our services, on research, and lots of useful information that you can pass on to your patients. We also have a library of continuing professional development online courses. We've got these now for a range of health professionals, and you'll be able to access accredited courses and also the recordings of past webinars. So I really encourage you to jump on the website. The QR code there will take you and have a little look around after. So without further ado, I'd like to introduce our presenters. We have Dr. Raj Chalasani and also Jo McKenzie. So I'll introduce Raj first. Dr. Raj Chalasani is an ophthalmologist and medical retinal specialist based in Sydney. He's a staff specialist at Westmead Hospital and also the visiting medical officer at Auburn Hospital. He has research interests in retinal diseases in Western Sydney, intraocular drug delivery, and intraocular lens design. Raj is actively involved in a number of retinal clinical trials, including several related to diabetic retinopathy. He manages a large number of patients in and around Sydney who live with diabetes and diabetic retinopathy. So thank you, Raj. I'll hand over to you now for the first part of the session.
Thanks very much, Vicky. I'll just share my screen now. Can everyone see my screen, hopefully?
Not yet.
There we go. How
Oh,
about
there
now?
we go.
There we go. Thank you. Thanks very much, Vicky. I firstly wanted to say thank you to the MDFA for the opportunity to talk to everyone. The MDFA does some great work in terms of helping all of our patients who have macular disease. So I'm very grateful for the opportunity to talk. Thanks to Jo, our patient, for giving up her time, and to all of you for giving up your time to join us today. So I'm going to talk about diabetic retinopathy, clinical aspects, and the care team. I'm based in Sydney. I am involved in a number of clinical trials related to diabetic retinopathy and macular degeneration for that matter at both my practice in Strathfield and in Hurstville. So certainly any of you who are based in Sydney who might have patients who are interested or could benefit from being involved, please reach out to us or to Vicky. I'm happy to try and help where I can. So as we all know, diabetes in Australia affects many people. Almost 2 million people have diabetes. Almost a quarter of those are undiagnosed. And it presents a significant health burden. Almost 1.3 million people are hospitalized every year. It's the seventh most common cause of death, and has a significant economic impact and cost as well. And of course, as we know, Indigenous Australians are much more likely to be impacted by diabetes and diabetic complications. And of course, we mustn't forget that for every person diagnosed with diabetes, there is a family member or family members and carers who also are significantly impacted in their role as support people. So, more specifically, looking at diabetes in the eye, um, the way I talk to patients, the way I explain things to patients when I see them, particularly for the first time with diabetes, is to explain that diabetes affects blood vessels, and this is usually something that patients are quite comfortable with understanding, and then they understand that we have what we call macrovascular disease, which is diabetes affecting larger blood vessels. And the biggest examples of these are heart attack and stroke. And then microvascular disease, which is diabetes affecting the organs with smaller blood vessels. And this includes the kidneys, the eye, and the nervous system. And so this is how I usually start the conversation when I see a diabetic patient. Of course, most of the time, by the time patients have come to see me, they've had a number of interactions with the health system and are already quite aware of a number of the risk factors. So I certainly try not to spend too much time lecturing them about the control of their sugars and cardiovascular risk factors, but I do mention it to them. And of course, there are other risk factors that tend to be associated with worse diabetes in the eye. That includes renal impairment, pregnancy, and genetics, particularly, for example, in Western Sydney, patients of Pacific Islander or Fiji Indian descent. As many of you may have already known, we have some key studies that were done overseas from a number of decades ago that really proved to us that intensive control of sugar and blood pressure does really slow down the progression of diabetic retinopathy. And these two trials are really the key trials that underpin our management of diabetes. And as I said before, one of the key things before we even talk about what's happening in a patient's eye is to make sure that they understand the importance of good control of their sugars to improving outcomes for their eye. And so, as I said before, when I see a patient, I do counsel them that diabetes affects blood vessels, and in the eye, it's the retina at the back of the eye that has all of the blood vessels. And so, this is the part of the eye that gets affected. And what happens in this sort of microvascular disease? So the over time, the high blood sugar leads to an impact on the cells that line blood vessels, what we call the endothelial cells. And so these cells have a really important role in regulating the flow of nutrition and oxygen into the retina and the removal of waste products out of the retina. And so the impact of diabetes is an impact on the integrity of these blood vessels. And so what happens? We have this stepwise change in the retina that occurs. We see initially what we call microaneurysms, which are these little red dots that start to appear in the retina. These are little outpouchings or weakenings in the wall of the capillaries in the macula. And then, not surprisingly, over time, the blood vessels in the retina start to lose their integrity. So we have both blood and fluid that spill out into the retinal tissue. And so we see this as retinal hemorrhages, as well as fluid in various parts of the retina. And these are all changes that we call non-proliferative diabetic retinopathy. So non-proliferative diabetic retinopathy is the most common form of diabetic retinopathy. And the important things to note here is that it can progress in a stepwise process. And in many of the cases, most of these stages can be completely asymptomatic. So initially, we might see what we call mild diabetic retinopathy, where we might only see microaneurysms or one or two hemorrhages. As we get more microaneurysms or hemorrhages, this then moves into what we call moderate diabetic retinopathy. And then finally, when we have extensive changes in the retina in all four quadrants of the retina, we have what we call severe diabetic retinopathy. And so this staging of the retinopathy, which can be entirely asymptomatic from the patient point of view, is really done to guide us as to how closely we need to be watching a patient. So someone with mild diabetic retinopathy, we may only need to see once a year, compared to someone with severe diabetic retinopathy, where we may need to see them every 3 or 4 months. And this is related to their risk of the retinopathy progressing to sight-threatening disease. One of the key things that can happen is the blood vessels in the macula in particular become leaky. And so this produces what we call diabetic macular edema. And so the way I explain this to patients, this image that I've brought up here is what we call an OCT, or optical coherence tomography. This is really the standard of care for looking after patients with macular disease. It gives us a highly detailed cross-sectional image of a patient's macula, which is the part of the retina that does their central vision. And so what happens with diabetes is you can initially start to see leakage of fluid around into the retinal tissue, and you can see this OCT shows some very early fluid in the form of those black spaces. But over time, particularly if the sugar and risk factors are poorly controlled, we can get quite significant macular edema, as you can see in this image here, where there is quite significant leakage of fluid into the macula. And you can sort of understand here how, with the fluid disrupting the normal anatomy of the macula, that the patient would have significant symptoms, most typically blurred vision or distortion, or straight lines starting to look wonky. So this is the most common way we assess for diabetic macular edema. We can also do what we call a fluorescein angiogram. A fluorescein angiogram we used to do a lot more of in the old days before we had OCT. But this is really still, I guess, the gold standard to assess the circulation in the back of the eye. What you can see in the figure on the left is the dye circulating through the macula at the beginning, after we've just injected it. You can see lots of white dots lighting up there. They are those aneurysms that we mentioned before that are filling up with the dye. And then, of course, at on the right-hand image there, what you can see is that dye oozing out of all of those aneurysms into the surrounding tissue. So it really shows us just how leaky diabetes can make blood vessels in the macula to produce that diabetic macular edema. And of course, as I mentioned before, if you leave fluid in a macula for a long time, eventually that will start to cause more permanent damage. So that fluid can interfere with nutrition getting to what we call the photoreceptors, which are the cells that detect light. And eventually those photoreceptors can die. And like any other nervous tissue, they can't regenerate. And that can lead to permanent loss of vision. So it is very important when we're seeing patients or treating patients with any type of macular edema to try and treat that edema reasonably quickly. So the other thing that happens in this microvascular disease is that diabetes can cause blockage of blood vessels in the retina. And so this leads to what we call ischemia. Ischemia is our medical term for lack of blood supply or lack of oxygen to an area. And so what happens when part of the retina is not getting enough oxygen? Well, it reacts by wanting to try and grow new blood vessels. And so you get the retina producing a range of chemicals that actually cause new blood vessels to grow. The problem is that these new blood vessels grow in an uncontrolled way, and we call this neovascularization, or essentially new blood vessels. And so the appearance of these new blood vessels is what we call proliferative diabetic retinopathy. And if we leave these new blood vessels to grow, they grow in an uncontrolled way. Eventually, they will cause bleeding into the retina and into the vitreous, or the jelly in the middle of the eye. And then eventually these blood vessels start to cause scarring and damage to the whole retina and the macula in particular, if we don't get to them in time, or if they've been left untreated. And this can be a significant cause of loss of vision. And you can see here an image of quite florid proliferative diabetic retinopathy. You can see around where the nerve or the optic disc is, there's a big bunch of new abnormal blood vessels growing. And there's already been bleeding into the vitreous, or the jelly in the eye. So we have to imagine this is a 2D image of a 3D structure. These blood vessels and blood are actually sitting in front of the retina, and you can see how this can cause significant damage. This is a fluorescein angiogram of a normal retina, and you can see here how the dye is nicely flowing through all of the blood vessels, and it's getting out to the capillaries all around the retina, which give the image a grey appearance. In between the large vessels, the retina looks grey because there is dye getting into the capillaries and smaller blood vessels. We compare that with a patient with proliferative diabetic retinopathy. What you can see here is that the spaces between the big blood vessels have all become black. And what's happening here is that the capillaries have all become blocked by the impact of diabetes causing blockage of the vessels. And then you can see the reactive response from the retina. The retina has started to grow all of these little new blood vessels that look like bunches of grapes. And they start to grow as a adaptive response. The problem is that they are growing into the vitreous and will, left untreated, will cause significant damage. And you can see the dye leaking from all of these new fronds of blood vessels. And if we leave proliferative retinopathy untreated, this is the end stage here, as you can see in this picture. These blood vessels start to scar, and you can see this is a significantly damaged retina with all of this white tissue is scar tissue that's extended into the macula, and this patient will have a significant impact on their vision. And in some cases, if this happens in both eyes, a patient can end up legally blind. So how do we treat these two key things that come from diabetes in the eye? So firstly, macular edema, our goal is to reduce the leakage of fluid into the macula and thereby allow the fluid to be resorbed and restore normal macular anatomy or structure. So the way we do this is with eye injections, and I'm sure many of you have patients that do receive eye injections for many diseases, but diabetic macular edema is a very common one. We have a class of drugs called anti-VEGF drugs, which basically act on the cells lining blood vessels to make them less leaky. And this can have a significant impact on improving a patient's vision. As you can see here, this patient has significant diabetic macular edema, had a course of injections, and you can see the edema has significantly improved. And this patient's vision will also have improved significantly as a result. Proliferative diabetic retinopathy, our goal here is to reduce the production of those chemicals or factors that are stimulating the growth of abnormal vessels. So the way we do that is to use a type of laser to the retina. And essentially what we're doing is we're applying retina to all of those black areas that we saw on the dye test before. We're trying to basically kill the retina in those areas so that it can no longer produce those chemicals that are growing new blood vessels. So it is actually a treatment with collateral damage. And so we are essentially applying this treatment to around the edge of the retina to protect the middle part of the retina, which is the most important part, the part that allows the patient to read and to do most of their everyday tasks. So there is a trade-off. Because we're applying laser and destroying parts of the retina that are involved with our peripheral vision and night vision in particular, patients who've had laser will have difficulties sometimes with their peripheral vision, but in particular at night time. Getting up in the middle of the night to go to the bathroom, for example, can become quite more challenging for patients. And these two photos illustrate what retinas look like that have been treated for proliferative retinopathy. You can see all of these white spots all around the edge of the retina are areas where we've applied laser. So all of those white spots correspond to parts of the retina that will no longer be functional. We try and leave spaces between each of those spots so that the gaps in the peripheral vision can be filled in by the brain, and that can sometimes be reasonably effective at meaning that the patient doesn't have too many symptoms in the daytime. But this area of the retina where we apply laser is the part where we have lots of what we call rods. The rods are the cells that are most active at nighttime, and so this is why patients have reduced night vision. But you can see that this does cause regression of those new blood vessels and allows us to protect the macula, which is in the middle here. This is the part that does the central vision. So that's just a rough, I guess, Cook's tour of what we do with diabetic retinopathy. And we of course, these treatments have been proven to be very effective, but there are many potential barriers to patients accessing and having treatment. Often our diabetic patients need to attend our clinic on multiple occasions to either get injections or to have laser done. This is generally during working hours, and many of our diabetic patients are of working age, and so there is potential loss of income as well as inconvenience. Transport, getting to the clinic can be difficult, and patients may need to rely on a carer to do that, particularly if they're getting an eye injection, they may not be able to drive themselves home. There is a cost associated with seeing eye doctors as well as any other specialist or healthcare worker, and this can be a barrier. And of course, there may be fear of treatment. I'm very used to seeing patients the first time and having to counsel them about needing to have an eye injection. And then, in actual fact, having an eye injection is generally nowhere near as bad as what people have imagined, but there is that fear of treatment initially. And of course, the importance of delivering treatment in a culturally appropriate way. And we must always remember that a diabetic patient is often seeing multiple other healthcare professionals, and this is quite a significant burden for them. And all of these things, as we can understand, can lead to frustration and also depression. So there's many challenges for us as healthcare workers looking after diabetic patients, and it's a multi-system disease. There are significant physical, mental, social, and economic impacts, and of course, particularly when it comes to Indigenous healthcare, we need to be mindful of delivering healthcare in a culturally appropriate way in order to encourage compliance with treatment and attending care. And it really is a collaborative approach. There are many different people, each with their own skill set, that are really important to allowing us to look after diabetic patients effectively. And all of these different types of healthcare workers are critical, really, to helping us achieve good outcomes. And that's really, I think, where the MDFA and iConnect do come in. We all are so busy in our clinical roles that sometimes it can be difficult to spend as much time with a patient as we would ideally want to. And having a service like iConnect, which really, I think, fills in some of the gaps with patient education and support, I think is really, really helpful for allowing a patient to understand the disease, the rationale between why we're doing what we're doing, also the consequences, potential consequences of not attending appointments, and also someone talking to someone who understands what it's like to live with the disease, and also a feeling of being able to take control of your disease, I think is very important, as well as providing some practicalities about things like transport, access to benefits or other services. These are all things that we would all love to talk to all of our patients about every single time, but sometimes we can't. We just don't have the time. And in many situations, the patient may not always ask the eye doctor, for example, everything that they wanted to ask. As much as we all try to be as approachable as possible, sometimes patients feel more comfortable asking someone else for some further information. And I think all of these things really help to provide emotional support for patients too. So in summary, diabetic retinopathy, it's an endothelial disease, a disease of those cells that line the blood vessels in the retina. Untreated, it can be potentially blinding. Control of the sugars and cardiovascular risk factors is always the most important thing first before you get to the eye doctor, of course. There are those two main key causes of loss of vision in the eye, diabetic macular edema, which we treat with injections, and proliferative diabetic retinopathy, which we treat with laser. We've gone over the barriers to accessing and maintaining treatment. Collaboration with all of you is really important, and of course, patient support services are crucial in my opinion. So thank you very much.
Thank you so much, Raj. That was, we just really appreciate you sharing not just your clinical expertise, but your clearly patient, your really patient-centered focus of practice. So really appreciate you being with us this evening. Thank you. So I'm going to introduce Jo next. So Jo, I don't know if you've got your video on, so we can see you. So Jo is a valued member of the Macular Disease Foundation. She's generously given her time to share her experiences living with diabetic macular disease, edema. She was diagnosed with type 1 diabetes at the age of 29 and is now managing her own eye condition. Jo always brings a really warm, down-to-earth perspective to everything that she does, and she is dedicated to supporting others by openly sharing her experiences and insights. So, thank you, Jo, for being with us.
Hi, everyone. Welcome.
So it's great to have you here today. I was hoping if you were happy to share a little bit on what life is like living with diabetes and how you manage your eye condition and everything that goes along with it.
Yeah. So as I said, I was diagnosed at 29. So this is actually my 20th year having type 1 diabetes. About 3 or 4 years ago, four years ago, I started to notice some changes in my eyes. And I mean, lucky for me, I have short-sightedness anyway. So I was regularly going to an optometrist. And it's something, I guess, when you're first diagnosed, that you definitely get overwhelmed with a lot of information, as well as learning about the disease, having to manage it, you know, count your carbs, so carb ratio to what you're eating. There is a lot that actually goes in. Plus, they also, you just get thrown a lot of information. Got to make sure your feet are good. You got to make sure about your nerves and your eyes, and it really was a lot to take on. But as I said, about 3 or 4 years ago, I got diagnosed with having some issues within my eyes, and at the time, my optometrist said, "Oh, you probably have to have some injections." And freak out. I'll be honest, the freak out. I mean, the mere thought of having a needle coming at your eye is just not something I think anybody would ever want to have happen to them. And, as Raj said, you really do overthink and about what actually is about. And in all honesty, I probably put my head in the sand for about a year. After that, I think after about a year, my optometrist said, "You really need to go and do something about this." And so off I went to a specialist who went through, I guess, everything with me. And initially, I started with the laser. So I've had laser in both of my eyes about 30 or 40 times. I think they did it when I had it done. And that wasn't, overly too bad. It was the hardest part was probably just having to stay still for the period of time. You couldn't move your eye or anything. And it really wasn't a long process. I couldn't drive afterwards, obviously, and so my husband had to come and drive me on home. And then I guess it just continued with checkups to the point that he said, "Actually, you're going to need these injections." At which time I transferred from being in the seeing him privately. I actually went to the public system, and have been basically having injections since January, February last year. So
And and Joe, that there's a lot going on. You've had a lot going on there. Looking back, is there anything that you would have liked to have known or that you would have found helpful in those early days? Because you said you sort of buried your head in the sand and it's understandable and I know you're not alone. But is there anything do you think that you could have heard that would have made you sort of do things differently?
yeah, I think probably understanding, I guess, the injection process a bit more than what I mean, you just get told you have to have injections, and you do sort of overthink, your mind definitely overthinks it. But for me, I think understanding it more around really what happens. Um, it's not something I like having done, but I now understand the process. So for me, I guess I'm a bit more detailed orientated, where some people are quite happy to go, "Oh, okay, I need to have injections." I like to know the process. So what's going to happen, how long it's going to take, and not just the actual eye injection, it's actually the process leading into that. I think understanding that a bit more would have helped. I guess probably not bury my head in the sand so much and make sure I got onto it probably a bit quicker.
Yeah. Would you mind sharing your experience of going through injections? Because as you said, you've been on them for a little while. How often do you have them, and how have you found it?
Yeah. So initially I did six round, what they call 6 rounds. So I actually have to have it in both of my eyes. And I choose to do both eyes at each time. I figured get it over and done with in one go and have 1 day or 2 days. So initially I had 6 rounds. So that was basically every month is what they started. And in between that, obviously after 3 rounds, I'd go have all the I guess the photos and all that taken of your eyes and checks done just to see how, if it's working, what's happening, what changes are happening within the macula. And then I was able to actually start to stretch it out. So the goal is obviously to stretch it out a little bit. And I was able to go to about every 2 months. Then I had to get changed around Christmas time. They decided to change me to a much stronger dose. or strength of having the injection. So I've had a much stronger injection dosage this year. And I've just recently gone back onto monthly. So I've found it's kind of working, but not really working. So I've had to go back onto a bit stronger, or in every month as opposed to every 2 months. So it's quite a
Right.
bit of impact there, yeah, with
Yeah,
the
well, I was going
change
to
in
say
things.
there must be a lot of juggling
Yeah,
because I know you work, you've got a
yeah.
family, there
Yeah,
must
so I
be a
got
lot
teenagers
going.
now, but yeah, so work as well, and everyone, we all have it. You have your home life that you've got to deal with. So yeah, it is quite a big impact, I guess. My husband obviously has to take a bit of time off work to drop me at the hospital. He has to then pick me up and take me home because my eyes are extremely blurry and I don't really see a lot. And he usually then works from home, so should anything happen, or you know I've got the support there on that particular day. So yeah, it is quite an impact with, having to have transport and people around just to make sure you're doing okay after it.
Yeah. Um, and I mean, we've talked before, Joe, but I remember you saying that you also had quite different, each injection wasn't the same experience for you either. You had different things going on for a little
Yeah.
while.
That was probably one of the biggest things, that I really just got told, oh, they'll be a bit stingy and they will bit blurry, I guess is probably the easiest way to say it, and which it was. But I found, each time, I mean, the very first time I did it, I couldn't keep my eyes open. I was in so much pain from it that even in a blacked out room, I really struggled to even keep my eyes closed or keep them open. I've had bloodshot eyes, I've had black spots occur in my eyes. When they inject, you get, I like to call it, little jellyfish pop up into your eyes. So that can take a bit of time before that disappears. Obviously, the blurriness and the stinginess, occurs. And that's something I found, it's almost something different each time I go in. My eyes sort of react in a different way. I think the worst one was changing to the stronger dose. Luckily, I'd said to my husband for this particular one, please come in with me. Normally, I'm sort of okay to your route pretty good, so I know how to get out of there and wait for him to pick me up. But this particular time, I said, oh, just come in just in case, and thankfully he did, because everything went very, very grey and very dark, and I really couldn't even see about a metre or so in front of me. So thankfully, I'd organised him to come in with me. So yeah, each time I just find something different crops up, and it's not something I was ever really told about.
Mm.
So having access, or as Raj says, often you don't get to speak to your patients as much in depth as what you'd like. So I think having better information like fact sheets or things about those, what goes on, or those types of different scenarios that could happen after your eyes, is then oh, is this really normal, or is this something I really should be ringing the clinic back about and talking through it? So
Yeah.
having that bit of information would be really good as well.
It it sounds pretty scary, Joe, that well, and a bit of a worry that you don't know what's going to happen each time you go. And so it's sort of understandable that, people might, you know, sort of put it off or maybe even consider not going. What makes you, keep on schedule and keep going back? What's the sort of drive for you?
Yeah, I think not losing my eyesight.
Yes.
That's probably my biggest fear, and I think it's the fear of a lot of people, is not losing my eyesight is the reason why. When I initially went, they said this is a 3-year process, so you need to make sure you're going to commit to this
Hmm.
for at least the next 3 years. So, I sort of, I remembered that. So I was up and ahead of that. So I was aware that I needed to put this commitment in. But my biggest drive would be, I don't want to lose my eyesight. And, I have had the vision changes a little bit more. I noticed little blurry sort of spots within my eyes. Like I could see things, but then there'd be like a section that I couldn't really see much. And I've noticed I've had to increase the size of the fonts on my screen and little things. So, when those sorts of things start to change within your eyesight, for me, I want to have my eyesight so I know I want to keep going on the regular schedule that's happening to make sure that I'm doing as much as I can to help improve.
Yeah, absolutely.
Mm.
And So you've sort of been living with, with the eye condition for a little while. How has your vision has it fluctuated? Has it been up and down through that procedure? Because you had the laser. Have you noticed the dark adaptation that, Raj was talking about, that some people experience?
Yeah, so I guess for me, as I said, my biggest one was having the blurriness. It has stopped me doing a particular task within my role, but generally most things I can adjust, like the computer monitor size. But yeah, think I've just sort of said, it's just really keeping going with all of that and making sure that any changes or anything that, seems even more out of the ordinary is go and do it. I feel lucky. I feel like the blurry sort of blacked out spot that was initially in my eye has certainly subsided to where it was when I first started. So I know that there has been an improvement for me, but I do still have issues of, I have to really increase the font size and squint sometimes to really read things. Like I really have to make sure I'm reading things properly and yeah, so that's sort of what I've been finding with it.
Yeah. Okay. And I just wanted to give you the opportunity. You've got a virtual room full of health professionals today. So the floor's yours. What can we do? What can you share? What can we do to make the experience, to improve things and just, help people more?
I think most definitely learn about, share that we've got the Macular Disease Foundation. I actually found it myself. I was never told about it. So I think knowing that that's out there would be really, really helpful for people. Once you've seen somebody, as you say, often it could be a month or two that you don't, before you go back in for your next appointment. And often you have questions. So connecting with like the Macular Disease Foundation has been great for having some of those questions sorted in between. I think having better information, so whether it be fact sheets or videos or whatever out there, and that's Australian. A lot of information I find is not Australian, so we really need to get some really more stuff on Australia. But using fact sheets to show what resources are available. So if there is the transport issue, for example, for some people, that what's available to people to access, or what symptoms you can experience and what's normal and not normal, and when you should go, I guess, go back after something that has occurred. There's sort of some other things. And I guess really just understanding that it's not just our blood sugar levels. I mean, type 1 diabetics, we all know our life just revolves around those blood sugar levels, and we know we've got to keep them really well. But there's a lot of other the health side effects that don't always get shared with you, or if they have, you've been overwhelmed with information that you often would forget that. So, I mean, a recent example for me is that I never really actually realized how big cholesterol was actually an impact on eyes, because that's actually something that's never been shared with me. So, there's so much, I guess, trying to get more better information back out to patients. So that, in between those visits, or if they come up with the questions, and, let's face it, everyone Googles,
Yeah.
it's making sure that they are able to access that kind of information.
Yeah, I was chatting with someone recently, and he has quite marked vision loss, not through diabetes related, but he just said, and it really resonated that he you spend time with someone, whether it through health appointments or whatever, and you sort of feel you have an understanding, but that person has to go home and live all their life dealing with this condition, whether it's vision loss or managing diabetes, and I think it's just really important that we all remember that.
Yeah, yeah. We walk out the door and we keep, we're still dealing with it. So it's a
Yeah.
24-hour, 7-day a week, 365. There is no holiday or break for us.
Yeah, that's
Yeah.
right. Well, I can actually see lots of questions coming through already. So thank you, Joe, so much for sharing, your really personal experiences. We'll hear more from you in a little bit. Just while we wait for the more questions to come through, I'm just going to share a little bit more on iConnect. So I shall do that now. So Basically, I mean, Joe and Raj have already told you a little bit about iConnect, but I'll just give you a little bit more information. Our regular attendees will know that it's been up and running already for quite a long time for people with age-related macular degeneration, but last month we launched for people living with diabetic retinopathy and diabetic macular edema. We have collaborated very closely with people living with the condition and also with Diabetes Australia and health professionals like yourselves. And we've adapted that macular degeneration service from what we heard across focus groups and things like that. And we've got a much more focus on mental health and well-being, as well as those really important treatment and information pieces. And as mentioned, we really work on health literacy. So we have developed fact sheets and lots of information on what you might expect, how things your vision might be affected, that practical advice and the emotional support. So we can provide that through phone calls at the moment with our helpline team, who are all experienced and trained to talk to people. And we also have peer support offerings as well. So I wanted to show you a little taster of what people receive. This is in the diabetes-related eye conditions journey. So they're with us for around 9 months, and every month you get a pack sent out. So one of these is in the form of an information pack. It goes either by email or by post, whichever the person prefers. And the content's curated based on their eye condition, what they have, their vision status, so if they do have any vision loss, and whether they are receiving treatment for that eye condition as well. So if you do want to find out more about iConnect, I'll be sending out all the information in the recording when it goes out later this week. So you can refer patients directly to MDFA, and you can use Oculo, and we also have a secure web platform. But we also know that you and your clinics are incredibly busy. We did also hear from our focus groups with health professionals that you do actually still like a visual reminder in your room. So we have created this flyer that's up on the screen. It's just really simple. There's 4 questions on there for your patient to answer, and it will just sort of figure out if someone would benefit from that extra support that iConnect offers. So some people use these just as a conversation starter to think about referring, or some people hand to their patients and then, recommend that they get in touch with us. So I'm going to stop sharing and let's have a look at some questions. So Joe and Raj, do you want to pop back on screen? So Raj, I think this is one for you. There's a question, what about anti-VEGF treatments for proliferative diabetic retinopathy? What's the future of these?
Yep. So here we're talking about proliferative diabetic retinopathy, not diabetic macular edema, which is the more common thing that we use injections for. So in actual fact, the same drugs that we inject for macular edema can also stop those new blood vessels growing, which is what we see in proliferative retinopathy. But the main problem is that so you can certainly treat patients with injections for PDR. The problem is that there's no end point because the underlying lack of blood supply is still there. So you can treat a patient, but you effectively have to treat them for the rest of their lives. And so for that reason, for most patients, you will do laser because once laser's done, it's done, and then of course you can be more comfortable if a patient misses an appointment, they're not going to suddenly get a bleed in their eye. But look, I do have a few patients, particularly maybe patients like engineers and things like that are a little bit concerned about the potential impact on peripheral vision, and for them, they're quite confident that they're going to be compliant. They get injections for the PDR.
Okay, thank you. So another question is about health professionals who can give eye injections and laser treatment to the eye in Australia.
So certainly in Australia, eye injections and laser can only be delivered by an ophthalmologist or an eye doctor. However, there are certainly other places in the world where eye injections are delivered by either most commonly nursing staff, particularly that would be the case in England in the NHS. So, but in Australia, however, it's purely ophthalmologists.
And when we're talking about providing counselling to patients regarding injections, Raj, do you have any tips regarding compliance, specifically for your regular checkups and just, that continuity?
Yeah, look, I mean, I always find with any disease that needs an injection, that first appointment is so critical. You really need to sit down and spend a little bit of extra time with the patient when you first see them to really try and explain the underlying disease and the rationale as to why you're doing injections. And so that really helps. And it's really common the second time you see a patient to really also make sure you're mindful that they will have had a lot of questions that come up in that first month. That everything just happens so suddenly the first time, and so it's really important to again have that extra time to answer those questions that will have come up. I find those first two appointments are really critical to I think developing a really solid partnership with the patient to ensure that they trust what you're saying. I think particularly with diabetic macular edema, I think you want to make sure the patient understands that you're only going to do an injection if you feel that they really need it, because diabetic macular edema, some patients are lucky; they might only need one or two injections, and then they can go back to being monitored. Whereas other patients will need a much longer period of treatment. So I find if patients understand, look, I'm actually coming into this consultation trying not to do an injection for you, and that we're only going to do it if we have to, that really, I think, builds trust with the patient as well. So these things are all very important. I think it's just having that solid therapeutic relationship.
Yeah, okay. Um, I think this actually leads, and I'm just going to skip one. Someone's requested, could you please go through the actual process involved in an intravitreal injection?
Absolutely, yes. So we I guess we all do injections slightly differently, or we never really watch each other. But broadly speaking, eye injections can be done as an outpatient procedure. So in the clinic, we of course need to numb the eye first, and that's done usually with firstly eye drops, and then usually some extra local anesthetic. Um, the eye needs to be cleaned with an with antiseptic agent in order to kill the bugs that we all have on our eyelashes. This significantly reduces the risk of infection, and so that's a mandatory thing. But that is also what causes a lot of the symptoms after an eye injection that Jo was talking about there. That irritation that comes on half an hour to an hour after the patient has left the clinic is basically the irritation from having had antiseptic put on your eye. And in some we either use betadine or chlorhexidine, and so you can imagine, normally if you put some betadine on your eye, it wouldn't be that pleasant. So that's unfortunately something that we have to do. The actual eye injection itself, is very quick. And if you've numbed the eye properly, the patient actually won't doesn't need to feel anything during the injection. And because you're sort of coming from the side, they don't see the needle either. So generally, in my experience, patients are very surprised pleasantly that it was nowhere near as bad as what they thought. But generally, most of the discomfort comes, as Jo was saying, in that 12 to 24 hours after an eye injection. They get that irritation. They also see what we call post-injection floaters, which is the drug swirling around in the vitreous in the middle of the eye. And both of these things do go away over 12 to 24 hours generally, but that they are quite significant things from the patient point of view and can be quite disruptive in terms of work. And so it's really important to explain these things before you do the first injection.
Yeah, absolutely. And I mean, a lot of the calls that we get on our helpline are certainly from people, receiving injections, and that those questions in between appointments, definitely, they do build up, and it is really great to be able to, help out and help keep people on track. Jo, I've got a question for you. So I think this is probably pre-injection. What helped you remain compliant with your appointments? Keeping track and
I think
keeping.
the biggest thing was right at the very beginning was being told that it is going to be like a 3-year process. They, as Raj has said, being upfront and telling people, is it only going to be a short period or potentially a longer one? And for me, it was I have to commit to this for a 3 year. And I think, as I said, I think the biggest thing, I don't want to lose my eyesight. Losing my eyesight meant not only just means losing the sight, it means I can't drive. There are so many different things that you can't watch TV, you can't, you don't see grandkids because you can't see them. You can only touch and feel and all that. I guess cooking, I've even thought about, can I now continue to cook? There's just so many things that it would impact for me. And so that's, I think, my biggest motivator is why I keep going along to these and getting the injections done and keeping on my schedule.
And another one for you, Jo. Is there anything that you wish that you were told about diabetic retinopathy? So before you had the laser, basically, when you were very first diagnosed.
Um, you got me on there. I can't think of anything. I mean, I had a very good ophthalmologist who did sit down and took the time, like Raj says he does with his patients, and went through, I guess, everything. I find always taking somebody in with you and taking a notebook and writing things down, I think are really, really good. So, it, I guess. Look, probably going back to, I guess, probably my diet is diabetes related, is, making sure that you've got, it's, as I said, it's not just the blood sugars, it's everything else. So, it's our blood pressure, it's our cholesterol, it's absolutely everything. And even if we do all of this, then, unfortunately, this can still happen.
Yeah.
So, yeah.
Yeah. Okay. Thank you. So, Raj, here's one for you. Is there any interesting research regarding new treatments for DR or diabetic macular edema?
Absolutely. Look, there's a huge amount of research going on, not only with I guess new eye injection drugs. There's certainly a lot of those being developed, and we're involved with some clinical trials with some of those. And the main goal of those, of course, is to be longer lasting and more effective. But there are various trials with tablet type treatment, eye drops as well for macular edema. And one of the I guess the maybe longer term ones are gene therapy type drugs where you inject a gene therapy into the eye, and I guess what you do is you're encouraging the cells in the eye itself to produce I guess a natural version of some of these drugs that we inject that can be just as effective.
So that the gene therapy could potentially be for DMO and proliferative diabetic retinopathy.
Correct, yes,
Yeah,
yes.
right. Wow. Okay. And what about other non-macular, so non-retinal conditions that also come, that diabetes puts people more at risk of? Someone's just asking about glaucoma or problems with night vision.
I mean, I think patients with diabetes, the most common other thing that they get at an earlier age is actually cataract. Um, and so it is very common with our diabetic patients that they will get cataract maybe 5 or 10 years earlier than the rest of the population. Of course, most of us, if we live long enough, all of us will get cataract, of course, and we're lucky that we can quite effectively treat cataract. That's actually the biggest other condition. Glaucoma, I think I don't think diabetes is seen as a direct risk factor for glaucoma. But certainly advanced glaucoma can often coexist with diabetes, and so that's also an important thing to consider. Patients having to use eye drops for their glaucoma as well as being treated for diabetes, and that can have an impact as well.
And just a last one on the injection. Where do you inject into? Is it into the vitreous? Well, it's an intravitreal injection, which means what exactly?
Yeah. So we use a 30 gauge needle, which is a very small needle, fortunately, and we do the injection through the white part of the eye, which and approximately half a centimeter behind where the iris meets the white part of the eye, and that area it's quite safe to inject the needle into the middle part of the eye, which is where the vitreous or the jelly in the middle of the eye is. And so the drug actually gets injected into the jelly and then it dissolves in the vitreous and actually gets access to the back of the eye where the macula is in that way.
Yeah, Great, thank you. So we've got an optometrist asking, when would you recommend referring into iConnect? Is it, and I can answer to this one, or you can as well. Is it recommended at the beginning? We've talked about information overload. Is it at diagnosis or point of ophthalmology referral? I mean, generally we sort of say there isn't an exact, it's different for everyone. People will be managing their condition and being very compliant, and you'll get a feel for that with your patients. But if there's any distress or any time where you think this person really does need a little bit of extra support, then that's usually when I refer in my patients into iConnect. But I think that just raises the point. It's really important to just every time you see someone, have a regular check-in and ask them how they're doing. Because one checkup they might be doing fine. Another, everyone's got lots of things going on in their life. Something else might be, struggling with, and they might just need that extra support for this side of things. Raj, do you have any kind of thoughts on that one?
No, look, I agree with what you said there, Vicky. I think it is very individualized. Definitely, you'll find some patients where there'll be information overload. They might have only seen the optometrist, yesterday or sometimes even earlier that day, and sometimes having a little bit of extra time to process things between the first and second appointments. It may be better to wait.
And Joe, I've just got one that I wanted to ask you just about because obviously you're having these injections regularly. Do you get any sort of not financial support, but are there any is there any help that you have with your appointments, getting to and from?
Financial wise, no, I don't receive anything. I do though, see some people that obviously have transport, so there's often, you know, things for them just from what I observe sitting in the waiting room. But for me, it's really just making sure you've got someone there afterwards to, help get you home, drive you home. I can't see. It's so blurry. It's no way I could drive after having my injections done. So that's probably the big one. But financial wise, there isn't really any support or, that we have for those things
Yeah,
that I have for me. I mean, for me, I live in Brisbane, so I live in a major centre. There, for people who don't live in there, there may be financial support, but I'm not aware of any specifics.
yeah. So I mean that is something that we can help with, as in not the financial, but we can help, share information about what's out there. But you're right, it's different. Each state and territory, they all have different things available. So it is quite challenging for people to find that information, and it's certainly something we can help with. And Raj, there's a question for you about any special gel or drop put in at the end of the procedure. Now we're back to injections.
Yes, that's right. So look, I mean, personal preference with different people in terms of how they do their injections, and also what the patient finds helps. Sometimes we do put a thicker lubricating gel in at the end of the procedure, or just a drop of lubricant. Other patients don't seem to need anything, so it's very much a personal preference thing.
Yeah.
There's also the other question that follows on there about avoiding the lateral rectus. I mean, in general, the rectus muscles start probably 15 millimeters behind where the iris meets the white part of the eye, the sclera. So
Do you want to explain what it is? Because not that we do have some non-eye
yeah,
folks.
so the rectus muscles are the key muscles that move the eye left, right, up, and down. And so they come from the back of the eye socket, and they I guess attach to the eyeball. But they start a bit further back, I suppose, compared to where we do the injection. So we're generally quite safe there. And look, you can do the injection anywhere 360 degrees around the eye, as long as it's half a centimeter behind where the iris meets the sclera, the white part of the eye. So some people will do them from below, some people will do them from above. I tend to do them from above because sometimes you can get a little bruise, but that's usually covered by the top eyelid if you do it from above. But personal preference.
Yeah. Okay, so I think we're probably coming up to time. I did want to just quickly mention, before I forget, there is a program called Keep Sight. So this is a Diabetes Australia initiative, and so it's basically a reminder system for people to have their eye checked. So anyone with diabetes, whether they have a diabetes related condition or not, you can sign up to Keep Sight through their website if you just Google Keep Sight. And that basically just really helps keep people on track with their eye checkups. It's not for injections at this point, but it certainly is there to try and keep people on track, looking after the general checks for their eyes. And Raj and Jo, can I get you both just to pop your cameras back on while I say a huge thank you for you both. We've had so many questions tonight. It's been a really, really great session, and we very much appreciate both of you giving your time and sharing everything. So thank you so much.
Thanks, Vicky. Thanks very much.
Yeah, thank you. You're welcome.
All right, and that we'll say have a nice evening or a nice afternoon wherever you are, and hopefully see you next time. Thank you.